affecting this part in the head and neck. Then can we dim the lights? First, in order to examine the Petrous bone by CT, we usually do both scans for the patient while he is in the supine position and in the prone position. In the supine position, we start by this, which is known as the scanogram, and this scanogram includes the area to be examined by CT, which is this region. And then we identify the area to be examined for the CT, starting from the skull base, proceeding superiorly until we reach the apex of the Petrous bone. And this is an example of the axial image while the patient is facing up. Then in the prone position, we start from posterior, then proceed until we reach the anterior aspect of the Petrous bone. And this is an example for the coronal images. Then, in order to know the anatomy of the Petrous bone, we divide it into three major parts: the external ear, the middle ear, and the inner ear. As you all know that the external ear is made of a cartilaginous portion and the bony portion ending by the eardrum. And this can be seen easily in the CT scan, and you can see the air in the external ear extending until we can reach the region of the eardrum. And we do not usually see the eardrum by imaging, but we know it's placed by this bony projection, which is known as the scutum, which is part of the tympanic annulus where the eardrum is located. Normally, the external ear is filled by air, and this air should be continuous until you reach the outside environment. Then we came to the middle ear, where the middle ear is composed of the middle ear cavity, which contains the ossicles and some of the muscles and nerves. This middle ear cavity is connected to the nasopharynx through the ostichian tube, is connected to the mastoid antrum via the adductus and antrum, and is also connected to the vestibule through the oval window and to the cochlea through the round window. And these structures can be seen easily on the CT scan. Starting by the anatomy of the middle ear, we should identify one of the most important anatomic landmarks, which is known as the ice cream cone. And this ice cream cone is formed whenever you are cutting through this part of the ossicles. Here you can see the head of the malleus, and this is the incus, short process and long process. Then whenever you see the ice cream cone on the CT scan, you can easily identify this is the head of the malleus and this is the incus, and the very faint line in between represents the oncodomalleal joint. Then you know that these ossicles are located within the middle ear cavity, which is connected to the largest cell in the mastoid, which is known as the mastoid antrum, through this narrow opening, which is known as the adductus ad antrum. Then look carefully at this section in the middle ear, where you can identify the middle ear cavity, and this is the head of the malleus, this is the incus and the short process, and you can easily see the oncodomalleal joint. Then this is once more the ice cream cone, where you can see the head of the malleus and the incus as well as the oncodomalleal joint. This is the middle ear cavity, this is the adductus ad antrum, and this is the mastoid antrum, and here you can see the mastoid air cells. Then if you go down, you can look here and you can see these two small bones, which represent the handle of the malleus and the long process of the incus. And here you can see these two bones as dots, and this is the anterior structure, which is the handle of the malleus, and this is the long process of the incus. Then looking at the long process of the incus, which is terminating by the stapes, and here you may see this is the long process of the incus and terminating by the stapes, which closes the oval window, which is this anatomic side. Then looking at the middle ear cavity below the level of the ice cream cone, you can imagine that it's almost similar to the foot of this sea lion. And if you look carefully here, you should see the two bones, which are the handle of the malleus and the long process of the incus. Then you can see the connection of the middle ear to the nasopharynx via the ostichian tube. And this bony ridge separates the ostichian tube from the canal for the tensor tympani muscle. Then if you look here, and you can see this very characteristic configuration, which is made of 2 depressions and 1 elevation. And the elevation is known as the tympanic pyramid, and the depressions, the medial one is known as the sinus tympani, and the outer one is known as the facial recess. Then looking once more for the anatomy of the middle ear, which starts by identification of the ice cream cone. Here you can see the head of the malleus, the incus, and you can see the oncodomalial joint, middle ear cavity, adductus ad antrum, mastoid antrum, and mastoid air cells. Lower down you can see the 2 dots of the handle of the malleus and the longer process of the incus. You can see the Eustachian tube, and also you can see the sinus tympani, the facial recess, and the tympanic pyramid. What happens if you go up above the ice cream cone? Then you can see that the middle ear cavity is only filled with air, and this air is separated from the brain by the well-known tegmen tympani, and nothing in the middle ear cavity here. Then, in order to identify the middle ear anatomy, you should locate first the ice cream cone. Then you can see the head of the malleus, the incus, the oncodomalial joint, middle ear cavity, adductus ad antrum, mastoid antrum, and mastoid air cells. Then you go down, then you can see the handle of the malleus, the longer process of the incus, then is the Eustachian tube, the sinus tympani, the tympanic pyramid, and the facial recess. If you go above the ice cream cone, then you can see the middle ear cavity, which is filled with air separated from the brain by this tegmen tympani. Then we came to the anatomy of the inner ear. We would like to see the vestibule, the semicircular canals, the cochlea, the internodutary canal, the cochlear aqueduct, and the vestibular aqueduct. Then what is the anatomic landmark in the inner ear? It is the lateral semicircular canal. And you know, we have the horizontal or the lateral semicircular canal, the posterior one, and the superior one. Then the horizontal semicircular canal will be cut in full section, as you can see here. This is the lateral semicircular canal, or the horizontal one. And you can see the canal by virtue of the fluid inside the canal itself. Then you know that all the semicircular canals open in the vestibule. Then this is the lateral semicircular canal opening in the vestibule. While cutting here, you can see the lateral semicircular canal and part of the posterior semicircular canal. Then if you look carefully to these 2 dots, and you can see that these are parts of the posterior semicircular canal. Then here, identifying the landmark, which is the lateral semicircular canal, then you can identify the vestibule and part of the posterior semicircular canal. Then look carefully once more, and you can see this is the vestibule, this is the lateral semicircular canal, and this is a part of the posterior semicircular canal. Can you notice that the landmark of the middle ear is exactly at the same level of the landmark of the inner ear if you scan the patient accurately and you adjust the angle of the scanning? Then look carefully at this section where you can see this is the vestibule and this is the lateral semicircular canal. These 2 small dots represent part of the posterior semicircular canal. Then once more, and you can look at this anatomic structures. Here you can see, and you remember the ice cream cone, the middle ear cavity, adductus ad antrum, mastoid air cells. And here you can see this is the vestibule, and this is the lateral semicircular canal, posterior semicircular canal. And you all know that this is the internal auditory canal. Then what happens if you would like to see the superior semicircular canal? You should go up. Then whenever cutting the foot plates of the superior semicircular canal, you can see only 2 dots. Then if you cut the dome of the superior semicircular canal, you can see a continuous line. Then if you go back to the anatomy, you can see that the lateral semicircular canal is almost at the level of the dome of the cochlea. Then if you would like to see parts of the cochlea, you should identify first our anatomic landmark, which is the lateral semicircular canal. Then you look here above the internodutary canal, and then the structure present here represents the highest point of the cochlea, which is the dome of the cochlea. And you can see easily the exit of the cochlear nerve from the internodutary canal going direct to the cochlea. Then if you would like to see the rest of the cochlea, should go down, because the highest point of the cochlea is at the level of the lateral semicircular canal. Then look here, this is the vestibule, and this is the lateral semicircular canal, this is the internodontic canal, this is the dome of the cochlea, and this is the exit of the cochlear nerve coming from the brainstem into the internodontic canal to supply the cochlea. Then the rest of the cochlear structures are seen while going down. Then this is the dome of the cochlea, and you go down, then you can see this very famous structure which represents 1.5 turns of the cochlea. Then if you go more down, then you can see the basal turn of the cochlea ending by this dot of air which represents the niche of the round window. Then looking once more, these are the anatomic sections in the cochlea, and you can easily see this is the vestibule, this is the lateral semicircular canal, and this is part of the posterior semicircular canal. This is the dome of the cochlea, this is the exit of the cochlear nerve. Lower down, and you can see this is 1.5 turns of the cochlea, lower than the dome of the cochlea. And more down, you can see the basal turn of the cochlea, ending by a dot of air, which represents the niche of the round window. Then, can you see carefully, this is the dome of the cochlea, this is the exit of the cochlear nerve, this is the vestibule, lateral semicircular canal, posterior semicircular canal, and this is the head of the malleus, this is the incus and caudomalleal joint. This is 1.5 turns of the cochlea. Then what about the cochlear aqueduct? This is of course the internodontic canal, and the cochlear aqueduct is almost exactly similar to the internodontic canal, but smaller in size and lower down in section. Then if you go down from the internodontic canal, you can see a small duct which simulates the internodontic canal, but is small and lower down. This is the cochlear aqueduct. Then what about the vestibular aqueduct? The vestibular aqueduct is present posterior to the posterior semicircular canal. Then look here, this is the vestibule, and this is the lateral semicircular canal, this is the posterior semicircular canal, these two dots. Then you can see this hairline structure which represents the vestibular aqueduct. Normally the width of the vestibular aqueduct is about 1 or 1.5 millimeter, but sometimes this vestibular aqueduct is very large, as you can see here in a patient with vestibular aqueduct syndrome. We'll discuss in the pathology. Then about the jugular bulb, and you know that the jugular bulb is commonly separated from the middle ear cavity by a bony ridge, and this is known as non-dehiscent jugular bulb. But in some patients, this jugular bulb is not separated by a bony ridge from the middle ear cavity, and we call this dehiscent jugular bulb. Then what about the course of the facial nerve through the Petrous bone? And you know that the facial nerve comes from the brainstem, going into the cerebellomontine angle, entering the internodontic canal, then going inside the Petrous bone until it reaches the geniculate ganglion. And here, this is the internodontic canal, and this is the exit of the facial nerve. And you can see this very famous configuration which simulates the figure of 8 in Arabic. And you can see the dome of this figure represents the site of the geniculate ganglion. And this is the ascending limb, and this is the descending limb. After that, the facial nerve will pass below the lateral semicircular canal, then enters the facial recess, then going vertically until it exits through the skull. Then this is the geniculate ganglion, and this is the exit of the facial nerve, ascending limb, descending limb. And you remember, this is the head of the malleus, this is the incus and caudomalleal joint, middle ear cavity, this is ad antrum, mastoid antrum, and this is the lateral semicircular canal and part of the posterior semicircular canal. Once more, this is the facial nerve, and this is the ascending limb, the level of the geniculate ganglion, the descending limb, and this is the lateral semicircular canal. Then, if you would like to see the nerve itself, and you should have an MR examination, then this is an MRI T2 weighted image, where you can see both nerves going inside the internodontic canal, and this is the dome of the cochlea, this is the cochlear division. And you all know that about 4 or 5 nerves crossing through the internodontic canal. We see only 4 of them. And the two most close, we should have this sagittal image looking from outside, inside the internodontic canal. And you can see 2 very close nerves, which represents the superior and inferior division of the vestibular division of the 8th cranial nerve. Then you see 2 divisions that are separated. The upper one is the facial nerve, and the lower one is the cochlear nerve. Then what is the value of the coronal images? And this is the coronal image where you can see this is the internodontic canal, and the bony ridge inside the internodontic canal is known as the crista transversalis, which separates the facial from the eighth cranial nerve. Then you can easily identify the vestibule, and this is the lateral semicircular canal, and this is the superior semicircular canal, and this is the cochlea. Then where is the oval window? And this is the site of the oval window, which connects the middle ear cavity by the vestibule. Then the course of the facial nerve below the lateral semicircular canal. You can see this is the lateral semicircular canal, and you can identify this very small dot which represents the facial nerve coursing below the lateral semicircular canal in order to go into the facial recess, then coming out through the stylomastoid frame. Then if you look here, and you can see this is the vertical part of the facial nerve coming outside the cranium through the stylomastoid frame, and this is the mastoid ear cells, and this is the styloid process. Then if you look here in this coronal image, you can see that the middle ear cavity is separated from the brain by this bony ridge, which represents the tegmentum tympani. Then this is the cochlea, and above the cochlea you can see these two dots. These are the ascending and the descending limbs of the facial nerve canal. And the one which is near to the middle ear cavity is known as the tympanic segment. And the other one which is away and near to the inner ear is known as the labyrinthine segment. And this configuration is known in our radiology books as the snake eye appearance, because if you use the MRI, you can only see these two dots and some fluid in the cochlea itself. Then this is the tympanic segment, and this is the labyrinthine segment of the facial nerve. By this, we came to the end of the first part of this talk about the anatomy of the Petrous bone. Then we'll use this anatomy in order to see the pathology. The first is the pathology in the external ear, and you know the most common pathology met in the external ear is the atresia of the externodontic canal, which may be of soft type or bony type. This is the normal appearance of the externodontic canal, which is filled with air. This air should be continuous to the external environment. Then if you can see that the externodontic canal is small and is filled by soft tissue density, which obstructs the whole way of the externodontic canal, then you can diagnose the possibility of soft tissue atresia of the externodontic canal. What's important is to look inside the middle ear cavity for other abnormalities concerning the ossicles and the middle ear cavity itself. Then if you look here, this is the right side externodontic canal, which is normal. But here you cannot see any externodontic canal, and the bone is almost subcutaneous. Then you know that this is bony atresia of the externodontic canal. Another example of bony atresia of the externodontic canal, this is the canal which is normally filled with air, and here you cannot see any canal, and the bone is immediately subcutaneous. This is the bony atresia of the externodontic canal. This is the axial images, and this is the coronal image showing no canal at all on the left side, and here you can see the normal canal on the right side. Then one of the lesions affecting the externodontic canal is this aggressive infection of the otitis externa, which can be diagnosed by CT whenever you can see that the externodontic canal is almost totally filled with soft tissue lesion, and this soft tissue lesion takes a contrast enhancement, and it also affects the parapharyngeal area and involves the pterygoid muscles and the infratemporal fossa. And this lesion may extend inside the middle ear cavity and is usually associated by erosive and destructive changes of the external canal, and maybe also the middle ear. This lesion is an inflammatory lesion usually seen in diabetic patients, and the clinical diagnosis is almost easy, but the usual role of imaging is to identify what's behind this infection in the external part of the externodontic canal. And this is the inflammatory reaction inside the externodontic canal, and the erosion of the head of the mandible, and the inflammatory reaction in the infratemporal fossa as well as the parapharyngeal spaces. Then we came to the pathology in the middle ear, and we're starting by middle ear infection. And middle ear infection will present itself in the CT images by opacification of the air inside the middle ear cavity. And this opacification should be dependent, meaning it changes with the patient position, meaning also it is a fluid in nature, it's not a mass. Then, because the cholesteatoma will appear like this, and in order to differentiate between cholesteatoma and simple middle ear infection, we change the patient position. If this opacity changes with the position, this is the dependent opacity, which is will represent infection, but non-dependent opacities usually represent cholesteatoma. Then this is a middle ear infection with opacification of the mastoid antrum and the surrounding mastoid air cells. The ossicles are intact, as you can see. Another example of middle ear infection, and you can see opacification of the mastoid antrum as well as the mastoid air cells compared by the normal finding on the left side. Another case of chronic otitis media, and you can see total opacification of the middle ear cavity in the coronal image. The tegmen tympani is intact, the ossicles are also intact. Then we came to the cholesteatoma, and we have two types, the congenital one and the acquired one. The congenital type of cholesteatoma is usually seen without a previous history of middle ear infection, and the mastoid air cells are usually clear. Then you can see an opacity which is similar to infection, but this opacity characteristically is not dependent. It is hanging in the middle ear cavity, and this opacity, if you inject contrast media, it does not enhance at all. Then the diagnosis of congenital cholesteatoma, I know it is easy for you by the otoscope, but on imaging you can see a small lesion here, and this lesion is not dependent, not falling down, and this lesion, if you inject contrast material, it does not enhance with contrast material. Another example of congenital cholesteatoma, and you can see this non-dependent opacity in the middle ear cavity medial to the ossicles on this left side. Then you came to the acquired cholesteatoma, which is usually the sequelae of chronic middle ear infection, and you can see here opacification of the middle ear cavity and some erosive changes in the bony margins of the middle ear cavity. What's important here is this part, which is known as the scutum, and this scutum is a very thin bone which is usually very close to the site of cholesteatoma, and whenever bone erosion starts, it involves this particular area first. Then this is the pathology of the formation of the cholesteatoma, and you can see this is the intact eardrum, then retraction of the drum, then formation of the cholesteatoma. These are serial images showing the cholesteatoma in the middle ear cavity, and you can see the middle ear cavity is totally opacified, no air inside the middle ear cavity. The ossicles are eroded, also the bony margin of the middle ear cavity is eroded. Can you notice also the sclerosis of the mastoid air cells? Another case of acquired cholesteatoma is an opacity which is non-dependent, and this opacity erodes the tegmen tympani, and it also may erode the lateral semicircular canal. Can you see here? If the lateral semicircular canal is eroded, then you will got the labyrinthine fistula. And this is an example of labyrinthine fistula, a cholesteatoma eroding the edge of the lateral semicircular canal, then creating a connection between the middle and inner ear cavities. Also, the tegmen tympani can be eroded, and the infection goes inside the brain and results in an abscess in the temporal lobe, as you can see. Then the glomus tympanicum is a small lesion which is also non-dependent. It's easily diagnosed by otoscope, but is usually it simulates the cholesteatoma. The difference is whenever you inject contrast material, the glomus is a very vascular lesion. It will enhance with contrast material, becoming more bright. Then if you look to this example, and you can see a lesion in the middle ear cavity, this MRI post-contrast, and you can see that the lesion is strongly enhancing by contrast material the diagnostic of glomus tympanicum. Then if you see an opacity like this in the middle ear cavity, you cannot differentiate between cholesteatoma and the glomus tympanicum unless you are aided by the clinical data from the clinician and you inject contrast material to see the enhancement pattern of this particular lesion. Fractures of the Petrous bone are usually of two types. The longitudinal one, which involves the longitudinal axis of the Petrous bone. And this fracture is very common compared to the transverse one and usually affects the middle ear. But the transverse fractures are relatively rare and they affect usually the inner ear. Then this is an example of a transverse fracture crossing the longitudinal axis of the Petrous bone, and you can see the fracture is affecting the vestibule as well as the superior semicircular canal. Then some of the complications of the fractures can be seen by CT like this, where here you can see that the oncodomanial joint is slightly widened, what we call the subluxation of the oncodomanial joint. And here you can see an air dot in the vestibule representing pneumolabyrinth. In the middle ear cavity you can see fluid which is hemotympanum due to blood in the middle ear cavity. In this case, here is the normal appearance, and here you cannot see the ice cream cone. You can see the ice cream, but you cannot see the cone, which is the incus has been displaced anywhere inside the mastoid antrum. Then these are two different cases with longitudinal fractures of the Petrous bone. Here you can see subluxation of the oncodomanial joint and hemotympanum. But here you can see dislocation of the oncodomanial joint and the hemomastoid. This is also dislocation of the ice cream cone. This is the head of the malleus, and this is the long process of the incus that has been displaced inside the mastoid antrum. Then we came to the abnormalities in the inner ear, and starting by this very famous pathology, which is the large endolymphatic duct and sac. You remember that this is the vestibular aqueduct, which is posterior to the posterior semicircular canal. This is the vestibule, and this is the lateral semicircular canal. The normal width of the vestibular aqueduct is about 1.5 millimeter. But whenever this vestibular aqueduct is very wide, then you got this syndrome, which is known as the vestibular aqueduct syndrome, which is one of the common causes of sensory neural hearing loss. By CT, this is the vestibule, this is the lateral semicircular canal, posterior semicircular canal, and the vestibular aqueduct is markedly dilated. By MRI, you can see that the duct and the sac as well, the vestibular duct and sac, filled with fluid by MRI. This is the vestibule, lateral semicircular canal, posterior semicircular canal, and the vestibule and vestibular aqueduct. The inner ear dysplasia are of two types, the Michel anomaly and the Mondini anomaly. Michel anomaly means total absence of the inner ear structures, and Mondini anomaly means abnormal configuration of the inner ear structures, including the cochlea and the vestibule as well as the semicircular canal. Then if you look to the dome of the cochlea, here it is expanded, and also the vestibule is expanded. On the opposite side, you can see abnormal configuration of the dome of the cochlea, and this represents the Mondini anomaly. And the Michel anomaly, if you look carefully on the Petrous bone on both sides, you cannot see any of the structures in the inner ear. And this is also confirmed by MRI, where you cannot see any fluid signal inside the Petrous bone on both sides. Then this is a Mondini anomaly, where you can see that this is the basal turn of the cochlea, and this is 1.5 turns of the cochlea, showing a little bit abnormal configuration. Then the dome of the cochlea is a little bit abnormal. And look here, this is the vestibule, which is wide, and this is the lateral semicircular canal, which is short and wide. And also you can notice the dilatation or the enlargement of the vestibular aqueduct, representing the part of this Mondini malformation. Then here you can see this is the normal example, and this is the vestibular aqueduct syndrome with enlargement, marked enlargement of the vestibular aqueduct. Sometimes you got abnormal enlargement of the internal canal, which is considered normal variant, unless you can see inside this canal a tumor mass or any abnormality. But this is a normal variant of mega internodontic canal, and this is the normal internodontic canal. This is the facial nerve, vestibule, lateral semicircular canal, and the middle ear cavity. Then a few words about otosclerosis, and here you can easily diagnose this by the presence of bony ridges inside the inner ear or obstructing the oval window. And you remember, this is the site of the normal oval window between the middle ear cavity and the vestibules, best seen in the coronal images. And in this particular case, you can see this is the vestibule, and the oval window is totally obstructed by this bony ridge, representing otosclerosis. Then look at this example. This is the dome of the cochlea, which is sclerotic, and this is the dome of the cochlea, which is normal. This is what we call labyrinthine ossification. Another appearance of labyrinthine ossification. This is the normal appearance of 1.5 turns of the cochlea. Then here, 1.5 turns of the cochlea shows dense bone sclerosis inside the lumen. Then this image is just to let you know the relation between the superior semicircular canal and the intracranial cavity. There is a bony ridge separating the superior semicircular canal from the intracranial cavity. When the superior semicircular canal is continuous with the cranium, then we call this the superior semicircular canal dehiscence syndrome. And you know, these patients usually suffer from drowsiness and dizzy appearance whenever they hear a loud voice. That's because there is a creation of what's known as the third window. This area should be obstructed by bone, but whenever the bone is deficient, then this will allow the vibration of the sound to pass through the semicircular canal, and this is normally does not occur. Then the patient will feel drowsy whenever he hears loud sounds. This is another example of, this is the normal appearance. The superior semicircular canal is separated from the cranium by bony ridge. But here, the superior semicircular canal is not separated from the cranium by bony ridge, which is known as the superior semicircular canal dehiscence syndrome. And using the CT scan, we can have these very beautiful images for the superior semicircular canal reconstructed in a sagittal oblique image. Then you can see most of the superior semicircular canal is separated from the cranium by bone, except for this area, representing the superior semicircular canal dehiscence syndrome, which is usually also and beautifully seen in this coronal image. This is the superior semicircular canal, and no bony ridge is separating the canal from the brain. This is the vestibule, and this is the cochlea, internal semicircular canal, and middle ear, internal canal, and middle ear cavity. A few words about the tumors of the facial nerve, which are relatively rare compared to the tumors arising from the intracranial nerve. And this is the facial nerve schwannoma. You remember, this is the ascending limb, descending limb, the level of the geniculate ganglia. And here at this particular anatomic site, you can see non-dependent opacity. This may be interpreted as cholesteatoma. In order to differentiate cholesteatoma from tumors inside the internal canal, we inject contrast material. Cholesteatoma does not enhance at all, but the tumors inside the middle ear cavity, including the glomus tympanicum and the facial nerve schwannoma, will show contrast enhancement. Like this one, and you can see a mass here, and by MRI you can see that the mass is taking contrast material representing a facial nerve schwannoma. The last issue is about the cochlear nerve atrophy. And you remember, normally you can see in the sagittal MR images, you can see 4 nerves inside the internal canal. These are the 2 divisions of the vestibular branch. And this is the facial and this is the cochlear. And in this case, you can see the vestibular branches and you can see the facial, but you cannot see the cochlear. And this is an easy diagnosis. Using an MRI sagittal images T2 weighted image, you can reach this diagnosis of cochlear nerve atrophy. And thank you very much.